All right. Well, I suggest we get started. We have a nice showing of people, and we'll get started here on time, relatively speaking. So first of all, thanks everybody for joining today. This is the first HIV/TB Inter-CFAR Working Group Webinar call that we've had. This is one of the activities that people were enthusiastic about doing a while back when we discussed what activities this working group could do. So in addition to in-person meetings, which are much harder to organize than this, we thought that doing web-based meetings would be great, just to hear about what people in the group are working on and what they've been doing, and to get to know each other better and look for opportunities for scientific collaboration. So I think this is a good example of the type of thing that we want to do periodically going forward. The schedule with which we'll do these, I think, is somewhat open, but I'd say multiple times per year, regularly, with someone from the group presenting their research and then having some time to discuss. So today, David Dowdy and his group are kind enough to get us started by talking about their study, Contact Tracing versus Facility-Based Screening for Active TB Case Finding in Rural South Africa, the Kharitode TB trial. This was published in PLOS Medicine in their special TB issue. Congrats, David and team, for that, published recently. But what they promise is a behind-the-scenes look at this to give us some insight into methodological challenges, et cetera. So why don't I just go around real quickly, and I'm going to announce your Skype name, and some of them it's obvious, but just say where you're from and maybe just a one sentence of what you work on. So I'm just going to go by the way they're popping up on my screen. So Kendall, Emily, maybe on mute.
Or Kendall, whoever is Kendall.
Kendall, maybe on mute. James Brust.
Yes, James Bruce. I'm at Einstein. I do drug-resistant TB and HIV in South Africa, specifically looking at bedaquiline drug-drug interactions and mechanisms of resistance.
Oh, can we also get people's titles just so we know what level of audience we're talking to?
Sure. I'm associate professor and an MD.
Okay, great. Karen Jacobson. Welcome, Karen.
Hi, thank you. I'm at Boston University. I'm also an MD, assistant professor. I do research on substance use, mostly alcohol, but also other smoke drugs and TB to understand outcomes and transmission. And I've also done work in spatial heterogeneity of drug-resistant TB, primarily in South Africa.
Excellent. Amy Honorato. Amy? But you guys have been getting emails probably from her. Amy?
Hi, everyone. Amy Honorato. I'm the program manager for Penn-CFAR.
Great. Megan Coe?
Hi, I'm a project coordinator for the Context study, which is through Emory University. I'm actually also here with another person. Megan.
Okay. Lynn Van Lith.
Hi there. I'm at Johns Hopkins Center for Communication Programs and do primarily social and behavior change interventions. And I'm really just sort of lurking to listen and learn a little bit more to apply to some of our work in Nigeria.
Okay, great. Sylvia LaCourse. Hi, Sylvia.
Hi, I'm Sylvia LaCourse. I'm at the University of Washington, also a physician, acting assistant professor, and I focus on improved case detection and prevention in pregnant women and children, primarily in Kenya.
Great. Michelle Larson?
Yes, I'm at Albert Einstein College of Medicine. I'm a PhD, an assistant professor, and I work on TB diagnostics in South Africa and also TB vaccine development.
Okay. Matthew McGee.
Hi, I'm a PhD epidemiology assistant professor at Georgia State University. I work mainly in TB and non-communicable diseases.
Okay. Leo Martinez.
Hi, I'm Leo. I'm a postdoc at Stanford. I do pediatrics and also transmission dynamic work.
Excellent. And then I have KRHARR3.
Hi, I'm Kristen. I'm an MD PhD student at Emory, working with Neil on XDR TB transmission.
Great. Ron?
Ron Coleman. I'm at the Penn CFAR. I'm director of the CFAR. I don't actually do TB HIV work.
And we have David, who's going to introduce himself in a moment. Sorry? Yeah, Vander F.
Hi, I'm Yuri Vanderheiden, MD, assistant professor at Vanderbilt University Medical Center in Nashville. Work mostly in South Africa, looking at acquisition of drug resistance and TB.
Great. Mary.
Hi, I'm Mary Armstrong Huff. I'm a PhD, an epidemiologist and medical sociologist currently at Yale, but starting next month, I'll be an assistant professor at NYU in the new Global Public Health School there in social and behavioral sciences and epidemiology. My interests are in the epidemiologic and implementation interfaces of TB, HIV, and non-communicable diseases, particularly diabetes.
Okay. Jen Ross.
Hi, everyone. I'm an MD acting assistant professor of global health at the University of Washington and also work at IHME. I'm joining tonight from Uganda, where I'm working on a study for geospatial modeling of TB HIV and also modeling IPT scale up.
Great. Joining from Uganda. Nice. Lee. There's Lee. You're still on mute. Okay. We'll go to Neil.
Hi, I'm Neil Gandhi. I'm an associate professor at Emory University. My interest is TB, HIV, co-infection, and drug-resistant TB.
Great. Krishna?
Hi, I'm Krishna Reddy. I'm an assistant professor at Harvard Med School, and I'm a pulmonologist at Massachusetts General Hospital, and I do cost-effectiveness modeling around TB, HIV, and tobacco.
Okay, excellent. Emily Kendall.
Hi, Emily Kendall. I'm assistant professor in infectious diseases at Johns Hopkins. I do TB, epi, and modeling of transmission and strategy for using new drugs and diagnostics.
Great. So, and I'm Greg Bisson. I'm an associate professor of medicine and associate professor of epidemiology here at the University of Pennsylvania. I do immunologic determinants of TB treatment outcomes and HIV TB and also host-directed therapy work, focusing a lot on pulmonary health. So David, why don't you take it away? Thanks everybody for the introductions.
All right, excellent. So I figured we would at least say hi to everyone. So I'm David Dowdy. I'm an associate professor of epidemiology here at Johns Hopkins and here with Colleen.
I'm Colleen Hanrahan. I'm a equivalent of a research assistant professor, also in epi here at Hopkins.
And it's a pleasure to be here with you guys today. I'm going to turn off our video now and see if we can share our screen.
Okay. And just a reminder to everybody, if you're not speaking, maybe just mute. So.
All right, let's see. Do people see the slides?
Yes.
Perfect. All right. Great. So it's a real pleasure to be here with everyone and exciting to see a lot of junior level people at this webinar. I think that what Colleen and I want to do is give you a bit of the backstory behind our trial of case finding for TB in rural South Africa, the Kharitode trial. I'm going to give a very brief introduction from more of a logistical sort of perspective, and then I'm going to hand the mic over to Colleen, and Colleen's going to present the methods results, but also some of the backstory, and then at the end, hopefully we'll have some time for questions. And again, these questions can either be methodological questions about how the study was conducted, etc., or logistical questions about how to get funding for an RO1, how to carry those things out. That's the nature.
And David, I would say just for the group, why don't we let you guys present all the way through, and then people just jot down questions, and we won't interrupt you. We'll just ask questions at the end.
Okay, yeah, I think that's probably the best approach. So, and we have kind of open questions at the end as well. So,
great.
All right. So, just by way of brief background, I think we're probably preaching to the choir here, but as everyone or most everyone probably knows, TB case detection is a big issue. It's estimated that 4 million cases of TB, of active TB, are missed every year, at least not notified to public health authorities. And these missed cases are probably a major contributor to ongoing transmission as well as morbidity and mortality. Particularly in rural settings, the best approach to improve case detection is unclear. It's difficult to carry out household contact investigation when people are spread far and wide and resources are relatively thin. So guidelines in general recommend contact investigation, but it's challenging. Facility-based screening is much easier, so have people set up in the facilities, but may not be as effective. And then there are innovative ways of potentially bringing contacts to us as opposed to having to go out to them. For example, offering conditional cash transfers to individuals who show up, contacts who show up for TB screening. And so we wanted to test the effectiveness and implementation of these strategies in the rural part of northern South Africa. We conducted a pilot study in this area, Limpopo province of South Africa, and found a 3.9% prevalence of TB among household contacts when tested by TB culture. This was published last year in BMC Infectious Diseases, and again, just by way of giving people a bit of background as to how this happened, this was actually carried out by a PhD student who received a small pilot grant at from the Center for Global Health here at Hopkins to go out for a summer and work with a team there to perform a household contact investigation study. Recruited 130 index cases, visited those households, was able to recruit 282 contacts, and found that out of 279 who did not have prevalent TB, 11 were positive on TB culture. So 10 out of these 11 cases were smear negative. We did not do expert testing in this pilot study. So we used this as preliminary data to apply for an R01 study. And again, for those who are on the career development path, this was my first R01. And so we used this pilot funding to put together this preliminary data. We had a team on the ground led by Neil Martinson at the Perinatal HIV Research Unit, who had some experience in TB and HIV in the area, and I think we were able to therefore demonstrate that we might be able to pull this off. I will say that I think that the unique setting, this being in rural South Africa, where it looks a little bit more like the rest of sub-Saharan Africa, but yet still has some of the infrastructure of South Africa, access to centralized lab testing, et cetera, I think was an important selling point. And I think in terms of selling the innovation of this, the idea of offering people incentives, as well as the study design that Colleen is going to describe, I think were both important in terms of getting the funding for this. So again, I'd be happy to, at the end of this, for those who are interested in talking about the process of applying and getting funding for this project, I'd be happy to discuss further. But what I'm going to do is turn this over now to Colleen and let her describe the actual study.
Okay, thanks, David. So what I've got here on this grant objective slide are the 4 objectives that we proposed with the grant, evaluating the acceptability and adoption of these different active TB case finding strategies, describing the comparative implementation, measuring the comparative effectiveness of the strategies, and then evaluating the comparative cost and cost effectiveness of each case finding strategy. And we're going to focus this primary, or not preliminary, but this first publication from this study focuses on the comparative effectiveness objective. So here's where the study was set. This map is showing South Africa, and the sort of highlighted region is the province of Limpopo, which David mentioned is a rural setting. As you can see, it borders with Zimbabwe, Mozambique, and Botswana. The province itself has the lowest TB incidence in South Africa, which is around 300 per 100,000. Just for comparison, the Eastern Cape province has the highest, about almost a little over 2 times the incidence at around 700 per 100,000. It also has a relatively low HIV prevalence compared to the rest of South Africa. For comparison, so it's about 9% in Limpopo province. The prevalence is around 17% in KwaZulu-Natal, which is the highest prevalence in South Africa. It's also a relatively poor province with the lowest average annual household income, and has a sparse population density. So this is where we were working for this study. I'm going to show you the study design, and this came straight out of our grant proposal. So year one, we spent basically doing some qualitative lead-in work, a bit of formative work on these interventions, and also spent a lot of time preparing our sites to implement the study, building the team, training them, doing this qualitative research, doing some preliminary setup to get everything ready to go. Then there was the first period of the study, which is what this analysis is focused on, was 18 months long, in which we compared facility-based screening at 28 primary healthcare clinics compared to contact tracing in 28 primary healthcare clinics. The contact tracing was split between 2 types of contact tracing interventions. The bottom one there is household-based contact tracing, and the middle one is incentive-based contact tracing. And I'm going to describe a little bit more about these interventions a bit later. So after that 18-month intervention period, that's where this study, this analysis focuses on. We then had 6 months of a washout period, and then the 2 contact tracing arms crossed over. So those clinics that were receiving household-based contact tracing then received incentive-based contact tracing, and vice versa. So that's the part of the study that we're in right now, and we will complete that data collection for that in January of 2020. So that gives you a look at the study timeline. The primary outcome for the study was a number of TB cases in each cluster started on TB treatment. One cluster was 1 clinic. There were 56 clinics in total. So why did we choose this outcome, the number of TB cases? You might think that what we're trying to see is really a change in the incidence rate, and that's true. We are ultimately trying to see that. And that would be more in line with how researchers, we think of TB, for example, going from 300 per 100,000 to 200 per 100,000. I'm sure you can imagine that's a very difficult endpoint. It's expensive, it's time-consuming, and challenging to measure. The ZAMSTAR study, if you're familiar with that, was looking at a decrease in TB incidence, and they ended up with a study population of around 1 million people. So, and that was funded, with a mechanism much larger than an RO1. And also, we'll say that we have really no ability to come up with a denominator for the population for this area that would be in any way accurate, I think, and reflect the true denominator that we're trying to go with. And at the same time, we acknowledge that rates are somewhat less meaningful to practitioners. They do tend to think in terms of the absolute number of cases. And in that way, it's more in keeping with our implementation goals of the study to look at the implementation of this, to focus on an endpoint that is more meaningful to practitioners, thinking like, well, how many more cases am I going to find if we use some of these methods? So to get a little further into what these case finding strategies were, the facility-based screening arm is basically the standard of care in South Africa, which recommends screening all attendees at primary care clinics using the WHO recommended 4-symptom screen. And then following the standard of care diagnostic algorithm for South Africa, testing symptomatic individuals using expert MTB-RIF. Then we had our contact tracing arm, which I mentioned is split between household-based and incentive-based. So household-based contact tracing, I'm sure many of you are familiar with. We start with a newly diagnosed index TB case. They consent for a team to come to their household. A team goes to the household and means their contacts present at the household for TB symptoms and tests with expert according to the South African algorithm. In the incentive-based arm, this was something we were trying. Started again with an index case of TB. We gave that person 10 coupons to refer close contacts to the clinic for screening. And then when contacts presented for screening, both the index case and the contact were given a small financial incentive. And then if the contact turned out to have TB, the index case received a large incentive. That's how those two contact tracing arms worked. I'm going to really talk about them as though they are just one intervention here of contact tracing for this analysis, and I want you to understand what goes into the contact tracing arm. I'm just going to return to the diagnostic strategy here to highlight that we were following the standard of care for South Africa, which is depicted here, showing that cases are screened with an expert as the first test. So I think that'll become relevant a little later when we talk about the reason why we saw what we saw. So we didn't do culture on top of expert at all. We just used the standard systems available in South Africa to test any presumptive cases with expert. In terms of our analysis, the primary analysis was then an incidence rate ratio comparing essentially the rate of TB cases found over the 18 months between the two arms, and that primary analysis was unadjusted. We also looked at an adjusted incidence rate ratio, accounting for any residual confounding by district and historical clinical TB case volumes of those clinics, so whether they had low or high volumes. And then we had some pre-specified subgroup analyses in which we looked at the incidence rate ratio by district, as well as by historical case volume. I should say that when we randomized clinics to receive the intervention, we randomized, stratified by both. The study covered 2 health districts, and we randomized then again constrained by this low and high case volume, so that we were not ending up with one arm having all of the high volume case clinics and one arm having all of the low volume clinics, or being influenced in that way. The study clinics are depicted here on this map. So showing you Polokwane is this small city, actually where the place that you would fly into if you're flying into this area. It's right in the middle. We did 56 primary care clinics in these two districts called Bembe and Waterberg Health Districts. As I mentioned, the randomization was constrained by a historical TB case volume, high, medium, and low. And 28 clinics received facility-based screening and 28 received contact tracing. Within the 28 that received contact tracing, 14 were sub-randomized to household-based and 14 to incentive-based tracing. Red dots are facility-based screening. The blue and green are the different contact tracing arms. All right. Not advancing. Our slides are stuck. Hang on just
there we go.
Okay, so what this looks like in the field, these are, the first two are showing our teams collecting data at the clinics themselves. The clinics do use a mixture of paper-based and electronic medical records. And the third, here's actually one I just took on a visit to the site through the back window of the car, where we were trying to find a household out in this area, and we had to stop and ask a farmer. That's our team on the tractor there, trying to locate a household out in this rural area, which kind of does highlight some of the challenges of case finding in an area that pretty rural, as we mentioned. In terms of our results, and this is just coming straight out of, I think all of the figures I present here come straight out of the manuscript or the publication that's available. So between these two health districts, we had 178 public primary clinics, out of which we chose 56 clinics. Mainly, the main choice was having a 56 largest clinics that were available. This is there are some very small clinics scattered here and there, and that would only have maybe 5 cases of TB a year. So we tried to choose the largest clinics. We also, in that year of lead up into the study, we visited these clinics, tried to assess whether they kept sufficient records for us to be able to, capture some of the data we were wanting, because we did depend on a lot of the routine clinic system record keeping to eligible participants for the study. So we needed clinics that kept sufficient records, were large enough, and were amenable to having people coming in and out for a study. We randomized these clinics, 28 to the facility-based screening arm, which is really just the standard of care, and 28 clinics to receive the contact investigation. During the study, one clinic closed in the facility-based screening arm. Luckily, the entire catchment area for that clinic was shifted to another clinic in the same arm, in the facility-based arm, and we didn't exclude that clinic that closed. We were able to include the data for the time that clinic was open, and then the catchment area was subsumed by this other clinic. So that worked out nicely for us. We didn't have any clinics lost to follow-up in the contact investigation arm. So ultimately, we analyzed 28 clinics per arm. In the facility-based screening arm, we had 1,929 patients with TB started on treatment. That was our outcome. And in the patient arm, we had 1,726 patients with TB started on treatment. We looked at the facility level characteristics. There were 2 types of clinics, community health clinics, primary health clinics, PHCs, which vary by whether they have a casualty department, and some of them do days if needed. And then we had characterized our clinics by whether they were rural, semi-urban.
Hi, I'm trying to get the office of Dr. Sarah Henn. This is Dr. Spalding. I'm calling from Emory University.
Okay.
Just a reminder for everybody to mute their lines if they're not speaking. Getting some background noise.
In terms of individual level TB case characteristics, we presented them here by arm, and what you can see is a picture of what generally TB looks like in South Africa. People are on average in their late 30s, a little bit, about 60% are men, and around 60% in both arms were HIV positive. This next slide depicts a bar chart of the number of TB patients started on treatment by clinic. So each bar represents one clinic, just the count of the number of patients started on TB treatment. The blue clinics are in the Vembe subdistrict, and black are in the Waterberg district. And then there's two bar charts. So the one on the left is for the facility-based screening arm. On the right, we have the contact investigation arm. And what you can see here is that, first of all, I think just by eyeball, you can see that there is not a tremendous difference between the number of cases started on TB treatment between the arms. We do see two very large clinics that popped up in the facility-based screening arm, and both of these clinics had a larger than expected TB case volume. And when I say larger than expected, I mean larger than what we observed during the year prior to the study, which is where we got the historical TB case volumes from. And I can talk a little bit later about how it could have been that these two clinics had larger than expected case volumes, but just keep this in mind when we're thinking about the findings. And so in terms of our main finding, and this is, I am presenting here the adjusted for residual confounding estimate. The incidence rate ratio comparing the yield of TB cases in facility versus contact tracing arms was 1.04. With a confidence interval that spans 1 and a p-value of 0.73. So in other words, there was no, essentially no difference between implementing contact tracing to try to get more TB cases started on treatment. In fact, there was this slight bias towards facility-based screening that was not significant. When we looked at the historical TB case volume, which was cut just above and below the median, we again saw that these estimates floated around 1, although above median, the higher clinic volumes had a 1.3 incidence rate ratio, also not statistically significant. And then by district, we again did not see a difference by district. So I'll just say that those, if we were going to have two clinics that had a higher than normal, what we previously had observed case volume, it was somewhat lucky for us that that occurred in the facility-based screening arm, which is our standard of care arm. So it really, gave a more conservative, potentially, bias to our findings, where we couldn't, if those two clinics had occurred in the contact tracing arm, it would be harder to separate out whether that was as a result of our intervention or whether it was just a result of some variation or change in what we had seen from the historical period that was unrelated to our intervention. The next slide is just showing a graphic representation of these estimates, in which you can see that all of them span the null of 1 for the rate ratio. In terms of the contact investigation arm, we screened 1,667 contacts of 789 new TB index cases. which amounts to 2.1 contacts per index case. That resulted in only 12 new cases of TB identified. So that is equivalent to a TB prevalence of 720 per 100,000. That's about a little over twice the incidence rate estimate for the province, but is far below what we saw in our preliminary data. And we'll talk a little bit about that in a second. So in conclusion, we can say that contact investigation, as we performed it, did not increase the rate of TB treatment initiation relative to a less resource-intensive, facility-based screening approach. Why? Well, especially why did we see so many more cases? We basically found the similar number of new TB cases from screening, almost 300 index cases, as what we saw by screening almost 800 index cases. So the pilot data found a much higher yield. One of the main differences that we can point to is that in the pilot we used culture as a diagnostic, which is more sensitive than a single expert, potentially, especially among HIV positive individuals, and especially potentially among those who have a low bacillary burden or early in their clinical course of disease, which is exactly who we're hoping to find among the contacts. So I think compared to culture, expert has about an 80% sensitivity, but when we look at smear negative or people with HIV, people with lower bacillary burden, that sensitivity can go down from there. And what we saw in the pilot data is that only one of the TB cases out of the 11 identified were smear positive. Smear positive assumed to have a higher bacillary burden. So what we can say is that in the pilot, we were finding people with low bacillary burden, exactly the kind of people we want to find with these types of interventions, and exactly the kind of people who might be less likely to be positive from a single expert. But we can see that the pilot yielded a much higher yield of TB cases, 3,900 per 100,000 versus 720 per 100,000. There could be some other reasons. For example, TB in general in South Africa is on the decline. So even over the 18 months of the study, we saw an incremental decline in the TB incidence throughout South Africa and in Limpopo province as well. So that could also certainly be behind a little bit of the difference between the pilot and our study, but we think that probably did not explain the majority of why the yield was lower. So for those of you familiar with TB diagnostics, what was used in, I think, about 99.9% of our index cases was the predecessor to the current version of expert. So I don't even know what people are calling it, the first generation of expert, I guess I'd say, and the new generation is called expert ultra. So the last 2 weeks of our study, in some of our clinics, they were switched over to using expert ultra, but it amounted essentially to the fact that almost all of these findings and these data come from using the first generation expert. Expert ultra is more sensitive than expert, and from this study done by Susan Dorman in 2018, I've highlighted here on the left her showing that expert had a 46% sensitivity among smear negative TB cases, whereas expert ultra gives a bump up to 63% sensitivity. So there's a new, more sensitive diagnostic out there, and it's being used. And you can see I've pulled back up the study timeline and the study design to show you where this is poised in our study. So basically, quite luckily for us, this changeover happened just before the washout period, and so The second part of our study is going to be digging into these contact tracing methods and comparing incentive-based versus household-based contact tracing. That was always our plan, and now we have an additional thing that we can look at, which is the change from expert to expert ultra, and seeing if that gives us a boost in the number of TB cases that we identify. We can hypothesize that it would, but we'll have to see. We're just completing the data collection on that, and I should say David is, as the PI of the study, is still blinded to any of those arm-specific findings. So with that, I'll just acknowledge the many people who were responsible for this study here at Hopkins, as well as our partners at the Perinatal HIV Research Unit of the University of the Witwatersrand in South Africa, and also acknowledge our funders. The R01 came from NIAID, and David mentioned this pilot study that was funded through the CFAR. And I think David and I have come up with some potential topics for discussion, which are sort of on the study-specific side, which I think we'll probably both answer, looking at the study design, which we're calling a hybrid implementation trial with a crossover subarm. Some of the challenges with using this account, just an absolute number of cases as our primary outcome with no denominator, these diagnostic testing issues. What are the implications of our study? Just, how did we interpret and kind of sell these null findings? Everyone, this wasn't the sort of slam dunk for one or the other. So how did we approach that? And then really from the career development side, I think those will mostly go to David about how did we write this. David didn't have a K award when he submitted this application. How much preliminary data is needed, how David and I think, functioned as a mentor-mentee relationship through this, and some of the issues around funding and study management. So thanks, and I think we can take questions now.
Yep, just to say thanks to all of you for listening, and yes, we're happy to take questions on these topics or anything else that's come up. Greg, I don't know what the easiest way is going to be to moderate these questions.
So I have an idea. So here's what I suggest. I mean, I have a question, so I'm gonna ask it right up front. But if people could just on your Zoom, there's some options. You can just send a message to me saying I have a question. Let's try that. If you can't make that happen, then you can just blurt out your question. And we'll try to manage it that way. But just text me via Zoom and say I'd like to have a question. I'll call on people then, and then they can ask their questions, so we can do it in that way.
Yeah, or just put it into the chat, right? So you go down at the bottom of the chat. You can type messages into the chat. But Greg, go ahead and ask your question while people type their questions in. Okay.
Yeah, and David, if you see chats coming up, just go ahead and call on people. How about we do that? Okay, so really interesting, and this is really the type of thing that I think is great to present here. The methods are very interesting, and the considerations that you had to go through in order to get this funded are really, really impressive. So just first of all, congratulations on a really interesting study and a really interesting result. I'm trying to figure out if I missed. One potential benefit to like a more aggressive screening strategy might be that you are capturing patients before they become smear positive earlier in the disease. Did you present the proportion of cases that were identified through each strategy that were smear positive? I didn't see that, I don't think, in the article on PLOS Med. But was there any difference? Are you catching them earlier with household strategy?
Yeah, I'll answer this. So we would like to have done that, but as I mentioned, we use the regular and this could be viewed as kind of a downside. So we use the standard screening algorithm for South Africa, and that does not include smear. So we do not have smear status. And I will say that as a study, the study paid for a proportion of those experts that were done. So even though they were done through the routine systems for TB, presumptive TB cases, we did have to pay for them. Experts are not cheap, even under concessional pricing. And that ate up a significant portion of our budget. And I think, it wasn't why we chose not to do it. We chose, I think, to use the standard diagnostic systems as it was an implementation while we're trying to do it pragmatically. Yeah.
Just one follow-up question then would be, and then Karen Jacobson has a question. Just one follow-up question would be, so was there any difference then in symptoms? Like were the patients in one strategy having fewer symptoms or less duration of symptoms? Do you know that yet?
Yeah, well, so we don't know that because our primary outcome was actually captured by looking at the study registers. So we were interested in, because we thought maybe having a more intensive intervention could have knock-on effects, that people find out that you're doing contact investigations so they come back in themselves. And so we wanted to see all, like the full effect of implementing this in each of the clinics, as opposed to just those who came in as index cases that we were able to screen. And so we don't have symptom data on all those cases. And just to say again, for those who are more familiar with the NIH funding process, this was submitted through the RFA for dissemination and implementation research. And so it was really billed as an implementation study. And that's part of the reason that we didn't do smear or culture, is that we felt that if this were to be implemented in South Africa, it would be done via expert, via the existing diagnostic modality at the time. And again, for better or for worse, that's the result is that as would have been implemented, at least under the old expert, we didn't see much of an impact.
Okay, so we have 3 questions coming in here with Karen, Sylvia, and Emily. Let's start with Karen. Karen, go ahead.
Hi guys, really interesting work. Actually, it's sort of a two-parter. I put up this, I don't know if you mentioned how you handle if patients come back either in your first arm or now in your second arm, and they are known to the clinic to have had TB, either completed in the last 2 years or not completed. Will they be included in your screening? And do you know, I know in the Western Cape, for the most part, if patients have had TB, they're supposed to get culture to confirm and not rely on expert ultra alone because of the issues around question of real or previous TB. Have you thought that through in your design, or given that this is, as you said, an implementation, you're just interested in overall numbers, and so you're letting the clinics sort of do that, and you're just watching the 2 ways of getting it, of them reaching the registries?
Yeah, I mean, great question, Karen. So in terms of thinking it through, this study predated Ultra by a couple of years. So we certainly weren't anticipating Ultra even being available widely at the time that we put this in. So right now, I mean, the way that we pull our outcome, and Colleen, you can correct me if I'm wrong, is that people are registered as a TB, the starting TB treatment, they count, right? And so if you've had TB in the past, we are not excluding those individuals. And again, this does get into some issues with people, for example, who are failing treatment, but I think this is a little different from what you're describing.
Yeah.
People
no, I'm saying lost to follow-up coming back in, or having completed and look like they're just a reinfection case or a relapse.
Right.
Yeah, I will say that with the second part of the study, the comparing the incentive versus the household contact tracing, we will know from those are patients that we've had a lot more, or sorry, the contacts are those we've had a lot more contact with. So we'll know for them the number and type of symptoms that they had. We'll know, we asked them whether they had TB in the past and how long ago. And so we will know some of those things and be able to kind of look a little bit more closely at that, especially since we have this natural setup for ultra versus expert. I know that what you described in the Western Cape, maybe what's happening, and I think we need to look a little closer into what's happening in Limpopo and those laboratories as far as how they're using expert. I know that there has potentially been a change about whether people who come up with a trace result, which is a very low low result for those who aren't familiar with it. I think there has been a change with whether they start treatment immediately or whether they have a culture confirmatory if they've had previous TB. So I think initially they were just starting them all on treatment, and they've switched over to doing a culture confirmation for those who had previous TB.
One other quick question is just that I know that they've done surveys in parts of South Africa around if you do facility-based, who actually makes it to facilities. And certainly grossly underrepresented are young men, are people who just don't routinely make it into clinic. And so the concerns around, even if you're getting the same rates, who you're actually getting for transmission has been raised. Is that something that you're thinking about in your analysis? I mean, you showed sort of the demographics of who was getting tested in the two approaches. Is that something you're going to continue to follow? And then I'll mute myself, but thank you. This has been very interesting.
No, great questions. And so we will have some of those data in this current study, but it's almost as if you're foreshadowing our next evaluation, which is going to be looking at performing contact investigation off hours. So looking in the evenings and holidays when people go home, where we're hoping to get more of those, not only young men, but also people who move around a lot. So again, I think great point, and point well taken. Hopefully 5 years from now, when we do this again, we'll have some more answers for you. Sylvia, you have a question about IPT?
Yeah, and so my question was, have you all looked at sort of secondary outcomes for either in these households or when folks came to the clinic for the TB cases that you found? Were you able to use these mechanisms to identify additional individuals that would have been eligible for TB preventative therapy, both as a potential contact and then additionally when you're screening that actual individual, if their screen was negative, did they get on to TB preventative therapy themselves? So thinking about sort of like other secondary outcomes on the prevention side. Thanks.
Yeah, I think along those lines, we follow the South African guidelines. So we counsel for under 5 household contacts about under 5 years of age who screen negative to be referred to the local clinic for evaluation for IPT. Our study did also do HIV testing in the household for the household contacts, and among all the incentive-based contacts, we offered it, and we didn't present it in this manuscript, but we did identify a number of new HIV cases that way as well, and those people we again refer to the clinic for the standard of care. So we are not explicitly following up the outcomes of those individuals for the study.
Yeah, I mean, I think it's a good point, and if IPT or TB preventive therapy implementation was better in this area, I think we would be concerned about the possibility of a negative bias in our results. So we go out and find so many people and put their contacts on preventive therapy, and we actually reduce the number of TB cases that are found as a result. But I think that, first of all, since we're only looking at this over an 18-month period, and second of all, that in general, TB preventive therapy is not really well implemented in many of these clinics at all. My suspicion is that we probably did not get a whole lot more people on preventive therapy, hopefully more people on ART from their HIV diagnosis.
Yeah, I think one thing that again could be interesting when we compare the two contact tracing arms is to see just which method yielded more potentially people who are potentially eligible for TB, especially the under 5 kids. So because those are how we know they're challenging to get started, and they are recommended.
Yeah, even if you couldn't, even if you didn't follow them as part of your study to see their outcome, obviously you could do, you could do an estimation or a calculation of how many additional people you reached that would have been eligible for preventative therapy. Yeah, great, thanks. I'll mute myself.
Yeah, no, that's a good idea. We should do that.
We got Emily.
Yeah, Emily.
Hi guys. I didn't introduce myself at the beginning. This is Emily Wong. I'm from MGH, but I'm also on the faculty at the Africa Health Research Institute in KZN, and we're actually joining from KZN, rural KZN today, and I have 2 other people with me, Susanna McCluskey and Sloan, a Harvard medical student. So the comment is, I just wanted to, this is super fascinating. And we started about a year ago doing a population-based screening for multi-disease screening, HIV, TB, diabetes, and hypertension. It's called Vukuzazi at Africa Health Research Institute. I think a couple of people on the call might know about it. But basically, we're doing gene X-ray ultra, midget culture, chest X-ray, and sputum symptom screen. And I just all the questions around kind of picking up on early, minimally symptomatic and kind of subtle disease, I think are, maybe some of what's going on here. Because we're certainly finding that, most of the community pickups are asymptomatic, and that's not totally surprising, but it's striking in the data. And gene X-ray ultra is, anyway, we maybe we could talk about it on another call because it could be quite interesting to follow on. But that was just, I just wanted to let you guys know about that. And then the question is, your incentive intervention is so interesting. And I was just wondering a little bit of feedback around how that's going and how people are finding the experience. And I'll mute.
Yeah, I mean, so certainly it'll be interesting to hear some of your results as they come out in KZN. And I'll let Colleen speak to this as well. I mean, we did some qualitative work early on looking at the incentive versus household contact investigation and people's preferences. And anecdotally, from those initial qualitative interviews, I thought that people were going to be really excited about the incentives. And I thought that we might even get to a point where people were going to overload our clinic staff with these incentives and people coming in and really having 10 contacts coming in per person. I remain blinded to the actual number of contacts in the two arms, but certainly it has, like, the average is only 2 across both arms, so it has not been a completely overwhelming success. And so I think that once implemented, people were a little bit less enthusiastic, and maybe it's because we weren't offering enough of an incentive. We were offering what, like $3 to $5?
Yeah, about that.
Yeah. But it's also been challenging in terms of arranging the time at which our staff would be there and people would come in for the clinics, right? Because we don't have full-time staff in each of these clinics, so we would actually have to arrange times for people to come in, make appointments with them to come in for their incentives. So that was also a bit of a challenge. So I think that there's a lot more work that could be done on this in this field. But just to say, I thought 2 or 3 years ago that this was going to be like a big raging success, and it wasn't really.
Yeah, I think I'll just add on to say that we have been very careful when framing these findings to say that this does not mean that contact investigation does not work. It's just that as you might implement it in South Africa following the standard of care in terms of diagnostics at the time using expert, it didn't result in a bump in the number of TB cases. So I think our you know, sort of push for the message has more been, you know, it matters, these details of how you, it's not a detail of how you do the diagnosis of TB, as precisely as you pointed out and we've said, among what we suspect are postbacillary cases asymptomatic. So your findings will be really interesting to see how they compare. And I guess just, you know, as David said, he's still blinded to the results of these incentive-based contact tracing. I will say stay tuned. It is going to be interesting, really interesting to compare what happened between the incentive-based arm and the contact tracing arm. And I think we've sort of floated doing airtime reimbursements to people, doing food vouchers. We ultimately settled on cash payments being the easiest to implement across the study area, with many other concerns. And with our formative research, people, of course, were open to receiving cash payments. I think it would be interesting in another setting where they have, like mobile money. I know, for example, in Uganda, people use mobile money, and that could be a much better way to reimburse people, easier than making them kind of come in and receive their payment. I think there's a lot of contact-specific things that go into the incentive arms and the tracing strategy, and I'm hoping that maybe we see more of this tried out in different settings, you know.
Well, all right. So I guess, are there any other questions? We're just at the top of the hour here. I didn't get any more chats. Guys, thanks so much for presenting today. Really interesting study and great to hear, you know, the behind the scenes take on how it went. And so in terms of doing these going forward, we'll schedule another date, you know, for maybe 1 or 2 months from now, and invite someone to present. If you're interested in presenting, just send me an email. And again, if you hear of anybody who wants to be on this email list, just tell them to send an email to me and I'll put them on the list, and we'll keep the group together. So thanks guys again for presenting, and I guess if there's no more questions, we'll end now.
Yeah, well, thank you, Greg. And just to say to everyone, if you guys have questions, please do feel free to contact us directly. Hopefully this can also serve as a way to build collaborative relationships among this group as well. So, and thanks to Colleen for presenting. And
yeah, thanks everyone. It was really fun.
Great. Okay. Take care, everybody. Have a good weekend.
Have a great weekend, everyone. Thanks.
Bye-bye.